Fibrous dysplasia is benign disorder characterized by tumor-like proliferation of fibrous osseous tissue in the bone. It is two types, monostotic and polyostotic. Monostotic fibrous dysplasia usually present in children and young adults. It is present as painless, slow-growing, facial asymmetry or swelling. It's common in the maxillary bone than the mandibular bone. It is smooth, fusiform, and enlargement is more common at the site of the lesion and present as a painless swelling. The involvement of the maxillary sinus in zygomatic process result in exophthalmos and proptosis. Involvement of ethmoid sinus, sphenoid sinus may lead to vision loss or compression of the optic nerve. The CT scan is the investigation of choice. If you see in CT scan, it is ill-defined lesion merges with normal bone. Early radiolution lesion passes through mottling and ground glass appearance, or you can say orange peel appearance. It is opaque and distorting the surrounding bone. The polyostotic fibrous dysplasia mainly affect female, ratio about 3:1, often affecting one side of the body. Most cases present in childhood with bony deformity and pathological fracture, occasionally with skin pigmentation and precocious puberty in female, and present as McCune-Albright syndrome. So, precocious puberty, skin pigmentation, and fibrous dysplasia. This is triad called as McCune-Albright syndrome. On histology, you can see this is Chinese character like pattern, or you can say trabeculae like a Chinese character is seen in the fibrous dysplasia. The difference between fibrous dysplasia and ossifying fibroma, the margin of this fibrous dysplasia merges with normal bone, while the ossifying fibroma you can differentiate on CT scan. There is distinct gap between the normal bone and the this ossifying fibroma. But in this fibrous dysplasia, it's erode the bone and there is no distinction between normal and pathological tissue. Gene responsible for this growth and differentiation of the osteoblastic growth are GNAS1 gene, which is leading to fibrous dysplasia that is mostly sporadic in nature. The management of fibrous dysplasia is if stable growth, you can excise the lesion if feasible. If there is no this growth is still going on, then you can go for biphosphonate therapy, or if stable growth, you can resect it if feasible. If you are unable to resect in some skull base part, then you have to decompress it by the drill or partial excision. So this is all about management of fibrous dysplasia.